Hi, I'm Sunny Hatch. I'm a scholar in the John P. McGovern Academy of Oshlerian Medicine, and today I have the distinct honor of speaking with Dr. Rachel Pearson. Dr. Pearson graduated from UTMB's medical school in Galveston, and there she was a student scholar in the academy and later became an emeritus scholar in the academy. She was also an active participant in the Ashbel Smith Osler Student Society and very active as a director at the St. Vincent's Clinic. Dr. Pearson obtained her PhD from the Institute of Medical Humanities at UTMB. Her dissertation was titled Medical Objectivity, the Narratives that Structure Knowledge and Identity in Medicine. Following her residency in pediatrics at the University of Washington, she joined UT Health Science Center as an assistant professor in the Department of Pediatrics and also has an endowed position in the Medical Humanities Center for Medical Humanities and Ethics. Well, excitedly, you were appointed the Ford Foundation Global Fellow in 2020. I mean, that just congratulations. That's phenomenal.
Well, thank you so much.
I understand you're interested in vulnerable populations, such as migrant children and their families, creating an equitable world and eliminating social injustice.
Absolutely. And that is, those are interests that I discovered through my training here at Galveston. So I definitely did not come into medical school hoping to save the world in the broader sense. I came into medical school because I thought it would be a really interesting life and that it would be a meaningful life. But I walked into St. Vincent's, before I even started med school, the summer before the first time, and training there, being in that space, I was like, oh my gosh, these are my people. Right? These are my patients. These are the people that remind me of my family. And getting to care for those folks at St. Vincent's and then, throughout med school, it made me realize that it's so much bigger than just caring for the individual patient. When you try to think about like all of the systems and everything that's affecting them, and you try to do a little piece of the work of changing those broader systems, just a tiny little piece is all anybody can do.
Like the social determinants of health, I guess that's what you're looking at, right?
Exactly.
It's amazing how broad that is.
Yes. Yeah, it really is. And I think it can get really overwhelming. Because as a doctor, you learn, poverty is linked to obesity, for example. And so folks living in poverty are more likely to have obesity, high blood pressure, high blood sugars, and all these things affect their health over the course of the life. And you think, gosh, what can I do about poverty? We're not necessarily always well equipped to address those social determinants of health, right? But even just learning about them and learning how important they are in our patients' lives and our own lives, quite frankly, I think it's a start.
I was interested in reading some of your writings, and obviously one of your work ethics is our shared humanity matters more than our difficulties. But you wrote, even before COVID now, any time we are isolated from our neighbors, fellow humans, or potential friends, we suffer. We suffer under the false belief that we cannot recognize, communicate with, and bend toward each other.
Yeah. Oh, thank you for reading that back to me. It still feels so true. And right now, we're in a moment in history where American society feels very divided. And since, thinking as a historian, I would say since the philosophical movements of the 1950s and then social movements in the 1960s, with the rise of postmodernism, not to get too geeky, but with the rise of postmodernism, we've seen identity groups grow in importance for how we think about what it means to be human. So I think about being a woman, that's part of my identity, and I absolutely feel solidarity with other women. race is an identity group, so I'm a white woman. And all of these groups have been so important in pushing for change, pushing for social justice, pushing for progress, pushing for us to think about vulnerable groups. Mm-hmm. At the same time, the notion of identity, as critical as it is for social progress, it can sometimes get in the way of us recognizing each other and really recognizing that fundamentally, because we are human beings, we have more in common than we have that separates us, and we always need to be reaching towards each other. And I think that's the fundamental act of medicine, is reaching towards another human being who is in need.
Obviously, these children coming over the border, they're an extreme vulnerable population, an extreme child that's in need. Is that right?
Yes, it is. So migrant kids are some of the most vulnerable people in the world. They're fleeing poverty, they're fleeing violence. In some cases, they're fleeing war. And here in Texas, we are very privileged to get to welcome these families and welcome these kids. And we don't always do it in the way that I would wish for us to as a larger society, but what I see in my work in San Antonio, which is a migrant hub, I see a lot of families passing through, and then I see some kids who were seriously injured or became severely ill in the course of migration, and who come across the border so sick that they then have to be transferred to my hospital in San Antonio, so I'm a hospitalist. And I've seen migrant kids who starved in the process of migration, so kids with actual kwashiorkor, kids with chronic disease or disability who rode on their parents' shoulders. I've seen a 4-year-old with cerebral palsy who was carried by her parents thousands of miles. She cannot walk. And they love her so much. They love her so much that they gave up everything they had and carried her here to try to find a safe life for her. And as is so often the case when you're caring for families, those parents are coming because they want their kids to get appropriate medical care. So you see kids with cleft lips that have never been repaired. You see kids even with straightforward childhood processes like asthma that haven't been cared for properly and haven't been getting the medicines that they need to live a full life and have a happy, easy childhood. It's completely possible for them to have that with the right medical care. And so to be in the position of the physician caring for migrant families, they have been hoping so much to see us and to get to welcome them and to get to say, I'm going to be a part of you, living that dream and getting your kid what they need. I'm going to be part of supporting your family. I'm going to be part of welcoming you. It's incredibly, it feels big and really beautiful.
I was going to ask you how you gain their trust, but it sounds like they do have an inherent trust of the medical physician anyways.
A lot of times they do. They do. And I'm a Spanish speaker. So when I was in high school, the Rotary Club in Port Aransas sent me abroad for a year. So I lived in Spain, learned Spanish. And that's also really critical in caring for the migrant kids from Central America in particular, to get to speak to a mother, like a worried mother in her own language. It matters a lot. And I think it's just like any other family, if you listen, if you take your time, if you really make sure that their questions are answered, it's not hard for folks to trust us. The
ones that you talked about with disabilities, you've got and you talked about many things in that one statement, but how do you've got the health education system also, right? Health and education combined, that these children will have to be integrated to.
Yes.
And I imagine they are probably the most at-risk children that are coming over.
So pediatricians have formed a nationwide network called the Migrant Clinicians Network. And so often when I see kids, they're passing through San Antonio and they happen to get sick. They happen to have a complication. And so they end up hospitalized with me. But then the challenge becomes, okay, so I have, a 4-year-old with medical complexity who's desperately poor and is traveling on to be with family in Florida, in Pennsylvania, in New York. The Migrant Clinicians Network has made it possible for us to get in touch with a team of physicians in the home destination, right, at their final destination, and help make sure that they are going to get hooked up with a pulmonologist or a, endocrinologist.
So like continuity of care, it sounds like. That's wonderful.
It's amazing, and it's something that pediatricians have really built from the ground up.
I wouldn't even considered it, because the acute crisis is so much.
That's true.
It certainly has to be taken, once you take care of them acutely, you have to continue to take care of them, obviously.
You'd worry about them so much, if you just sent them out, it really wouldn't be tolerable to just send them out. You have to make sure you can pass them on.
Well, speaking of such, many have undergone relocations or unstable housing conditions once they get here anyway. And so they don't really have a true home established.
Correct.
And many have come over without parents, I understand. And parents, they know that they can't get across, so they send their children just to make sure that the child has got that opportunity. How do you deal with that child that doesn't have, the authority to make decisions regarding their health?
Right. So that's a complicated question. Children who come across unaccompanied are initially in the custody of the Office of Refugee Resettlement, and so some of those kids, if they come to the hospital from a Border Patrol facility, for example, say they get there, they get sick, they need hospitalization right away. At that point, the medical decision maker for them is Border Patrol, right, or is the Office of Refugee Resettlement. And so that's the person who says, yes to, who consents to treatment for the kid.
I see. They serve as a surrogate for power of attorney, medical power of attorney.
Exactly, but we also get on the phone with the parents, and that's sometimes complicated. So for example, we had a kid who'd come up from one of the Office of Refugee Resettlement centers, and his mom could walk to a village that had a phone on Saturdays only, and he could reach her by calling the store in the village. And so we had to wait till Saturday, call the store, get in touch with the mom, and that was the system that they had set up. A lot of these kids, can get in touch with their parents on WhatsApp or on cell phones. And so even though they're in the custody of the government, we also try to really respect their parents and bring their parents into care because their parents are worried about them.
Well, they're certainly at risk also for human trafficking, right? So we know that does exist. In fact, Texas mandates training of physicians in the management and recognition of human trafficking. So from what I understand, children are vulnerable to exploitations not only for sex, but for labor, forced criminal activity, as well as illegal adoption. What have you seen in that regard?
So I've seen a lot of kids who describe before migration, working, doing manual labor from a very young age. As a result of their family living in poverty, and them not being able to access education. Some of these kids have been working from 5 years old, 6 years old. But then you're absolutely right. After migration, they remain incredibly vulnerable to exploitation. So there are kids who are in school falling asleep because then they're going and working a night shift at a factory, at a center, legally or illegally. In fact, in the case of asylum-seeking kids, it's not legal for them to work, even if they're over 16 or whatever. And their parents are in the situation when intact families migrate. So when a family is given the legal right to enter the country as asylum seekers, they're not given a work permit. They're given that legal right because they have a sponsor, another family member living in the United States, who says, okay, I have the means to support this family for the next year. And so they're meant to not work and wait for their case to pass through the migration system. At that point, they're either granted asylum and then they can start working, or they're deported. Okay, and most families are ultimately deported, actually. Most asylum-seeking families are. But in that time, while their case is processing through the migration system, most of them really cannot survive without doing some kind of work. And so we see a lot of them working in in an illegal capacity or working in an underground capacity, adults and kids.
So how do you promote equitable care under those situations?
That's a great question. I mean, that's a lifetime question, So the first thing is to be kind to the person in front of you, to care for the kid, care for the family, and be respectful of them. At the same time, there is a whole network of community organizations who are pushing for a more just system for accepting and processing migrant people. And so I suppose I go about it in two ways. And one is serving as a community or serving as a medical liaison to some of these organizations. I will let them know, in general terms, like what we're seeing in the hospital, what we're seeing at the border from a medical perspective, and then they'll use that information in their advocacy. The other thing is writing about these issues, because as physicians, we really see the way that injustice acts out on the body. So that kid, that toddler who starved during migration and came in near death with kwashiorkor, his body shows what poverty, what injustice can do to a child. As physicians, we bear witness to that. And so we are so uniquely positioned to see that and to witness, not only in the sense of seeing, but in the sense of speaking out. That I feel that I could not do the work that I do and not speak out about it, not write about it. I just don't think I could morally continue without speaking out about it, because I have, and physicians in general have, this unique lens, this really unique picture of how things really play out in people's bodies and people's lives. You could say, you could throw out a statistic like, oh, if we cut food stamps, then this many more kids will will be hungry at school. But then as a doctor, you see like, okay, now I'm seeing X, Y, and Z. Kids are losing weight, not able to concentrate. And now I can describe what it actually looks like for children when we make these policy choices.
Those are excellent thoughts. I imagine a lot of these families and children wind up at clinics that are charity-based or faith-based clinics. You talked about St. Vincent's. Can you talk about St. Vincent's a little bit?
I would love to talk about St. Vincent's a little bit. Yeah, so, St. Vincent's is the student-run free clinic here in Galveston. It was started by Dr. Beach, Dr. Robert Beach, and a team of med students in collaboration with a historically African-American community center, St. Vincent's House. And over the years, it has evolved and changed in many ways. At the time that I was there as a student leader, St. Vincent's was serving a huge mix of patients. Lots of folks who were uninsured or underinsured. Lots of folks who fell into the gap, what we call the Medicaid gap, where they made too much money to qualify for Medicaid, or they did not have dependent children, so couldn't qualify for Medicaid anyway, but they didn't make enough money to get private insurance. So lots of Texans are in that situation even today. And at St. Vincent's, as a student, you have this time to sit and get to know your patients and really just listen to them. And that being in that really special space where the patients felt safe and I could sit and like be with them as a human being, it deepened my life so much, and a little bit it changed me, right? It changed what I think it is to practice medicine, and it changed the scope of the impact that I think doctors can have on the world. To see people like, Mr. Rose, who I talk about in my book, who was a working class guy from Galveston, and who had kind of gotten sicker and sicker and sicker, hadn't been able to access medical care, and came to St. Vincent's. And was so kind and so funny, and so giving of himself and his own stories, even though it turned out he was really sick. Those charity clinics, those free clinics, they're limited in scope. So at St. Vincent's, what I always say is there were a lot of times where we could diagnose, but we couldn't always offer comprehensive treatment. So we would see folks with cancer, like we eventually discovered Mr. Rose had, or, decompensated heart failure, for example. Folks who had heart attacks, folks who had, lupus with kidney disease, chronic autoimmune diseases, complex illness. St. Vincent's can't make a $15,000 a year biologic fall out of the sky for a patient who needs it. Can't make surgery happen, can't make chemotherapy happen. And so a lot of what you end up doing is, on the one hand, struggling really hard to get your patient that comprehensive care they need. That's one thing you do. Another thing you do is sit with those patients and bear witness as they go through their disease process. And another thing you do is you learn to sit with suffering that you cannot ameliorate.
That has to be awful.
I mean,
You're a physician, and I imagine you feel helpless during those periods of time.
Yeah, you do. You do.
You wrote about some of that in No Apparent Distress.
Mm-hmm. It was really formative for me, just that sitting with patients, and especially because I was here at UTMB. I was getting my training. I was learning. Okay, what does the standard of care look like? Okay, what should each of these patients get? And to know what they should get, and to see the gap between what they should get and what they were getting, and to see that how many people I cared about, like my patients. It made it very clear that those gaps in access to care are intolerable. It's intolerable, not just for patients, but for physicians too. I really believe that to be the physicians we want to be, like to be the really good doctors who feel good at the end of the day, like we've done our moral work, we've made sure our patients are appropriately cared for, we've done what we could. We, in order to be whole as people, need a more just system of delivery of care. And I would say we need everybody here in this country to be able to access a doctor and comprehensive medical care when they need it. I think it's really hard on the students because they need to believe that they're going to be able to go out there and save lives. They need to look at becoming a doctor and see, oh, wow, I'm going to be able to do so much, and my profession is good. My profession is good. When they see instead, oh, it's limited in all these really important ways, and my profession is letting certain kinds of people fall through the cracks. My profession is involved in allowing some people to die because of their social circumstances. That hurts the students who are in this process of moral formation. And it's something that we really need to fix.
You spoke about access to different specialties. There was actually a visiting scholar here in the academy. It was Dr. Denise Rogers. And she reviewed with us an article but it was from the Journal of Multidisciplinary Healthcare. And the paper was titled Reducing Healthcare Disparities in Underserved Communities via an interprofessional collaboration across healthcare providers. In other words, bringing more specialists, not just the Robert Beach or, the Bernard Carnaff, more, And actually, I'll let them tell you later on today, but they have brought in other specialists over there now. But her concern was you take the sickest population that we have and we put them in the hands of students. Mm-hmm. How do you feel about that?
It's not just in the free clinics that students are caring for the sickest population in America. It's also in teaching hospitals, which tend to be public hospitals, county hospitals. Our medical students across the board are training on the poor. And when they work in free clinics, when they go out and do global health missions, they are training on the sickest and the most vulnerable people in the world. And I do believe that creates, unfortunately, a perverse incentive within medicine to maintain a population of people who do not have access to other ways of getting care, people who will accept care that is student-driven, people who will accept the shortcomings of informal clinical spaces because they don't have another option. that's not okay. And it's also not fair to the students, because they should be training in more diverse spaces. It does mean that medical education is a fabulous social education. It's a fabulous way of learning about class, about race, about the structures in our society that make some people sick. The fact that, as Dr. Rogers points out, the sickest people are in the hands of our trainees, that's not fair to them.
You know, I've really loved talking with you today. I'd like for us to go over to St. Vincent's and get your perspective of what it is now versus what it was when you were a student here. But before we go over there, you've told me before you've got a very special skin art. Would you mind sharing that with us?
Okay, I have a tattoo, an equanimitas tattoo, and it's on my shoulder. Okay.
Aquaminitas.
Equanimitas. It's my favorite virtue.
So when you went to your artist, did you have to spell it out to make sure?
I actually Googled it to make absolutely sure, and the script on there is from actually Osler's book.
Oh, wonderful.
Same script that appears there. But yeah, I've always really loved equanimitas because I have come up in medicine in a time of like wellness culture, and where trainees are given this idea that if we do enough yoga classes and enough mindfulness that we might have balance and we might have wellness. And I really think that Cicero and Osler had something right in just saying, actually, we sail in stormy seas. As physicians, we sail in stormy seas, and we need to learn to be the place of the calm. I think that the moral work that we have to do to maintain ourselves, our fortitude, our centers in a career in medicine is much bigger than wellness culture can offer. It's learning to be that calm. And that's what Osler was talking about. That's what Cicero was talking about. That's what the Stoics cared about. And that's what that tattoo reminds me of, that the seas are always going to be stormy, but one must continue.
Set your sails, right?
Yeah.
Set your sails. Okay. I love talking to you. Let's go look at St. Vincent's.
Okay, let's go.
Thank you for your participation in our discussion today. As is always, Osler remains relevant to today, tomorrow, and the future. Remember, as always, to practice medicine with your head, your heart, and your hands.